So good evening, everybody. I think we are likely good to kick off. Shelmith, I don't know if you can hear me just as feedback. Sorry, one of my connections went off. I've had to log on again.
Yes, I can hear you.
Awesome. Okay, thank you. So welcome everybody to today's Kenya Society of Anesthesiologists hosted weekly webinar. I can see, as always, we have a nice audience spanning the globe even. We thank you so much for joining us. As always, it is an extreme pleasure to host you, our growing family from various allied specialties and cadres. I say this every week without shame. It is because of you and for you that we congregate. Today, our invited speaker, Dr. Anthony Kamau, we thank you for taking the time to join us, to join hands with us in this exchange of knowledge. The Executive Committee of the KSA for organizing this series. Our sponsors this evening is Troikaa. We thank you for partnering with us, not just today, but on various other ventures. To the Kenya Society of Anesthesiologists and all her members and partners, Ms. Shelmith Macharia, we thank you for the smooth running of this forum, for organizing everything and ensuring that it's seamless. I am Angela Ongewe, and I will be your moderator this evening. Ask that we keep our mics muted as usual and our videos off for the duration of the webinar. I welcome you to write your comments, questions, contributions in the chat box, and we'll address them during the Q&A.
It's a topic that I'm really glad that I was given, because it's usually the bane of my existence, the embarrassment, the hope that the patient usually looks at you with when they want to just have their surgeries done, the assurances you gave them. It's something that no anesthesiologist wishes on even their worst enemy. So my objectives today are just to do a brief introduction, discuss the mechanisms of failed spinal, talk about how to prevent a failed spinal, how to manage it, and then finally how to, we'll conclude. So Gaston Lambert in 1922 stated that there are two conditions that are necessary for any spinal anesthesia. So that would be one, a dural puncture, and the second one, injection of an anesthetic agent in the subarachnoid space. So this has been almost 100 plus, or no, just almost 100 years of trying to do this one thing, and yet it sometimes proves to be really difficult. So just to introduce what the definition of a failed spinal is that it's when we attempt an anesthetic and there is no resulting block, or the block is inadequate. And the three components that can contribute to inadequacy of the block, we can talk about either it's the extent was not adequate, the quality of the block, or the duration of action of the local anesthetic was the one that was inadequate. Block failure can be due to a few things. Commonly, the clinical technique, meaning maybe you're trying to do it from an area that it's not supposed to. Inexperience, that means an unsupervised trainee. I'm not too sure if I found that when I was being supervised, my spinals never worked. So I'm not too sure about the unsupervised trainee. Maybe there's stage fright when there are people, but still that inexperience does contribute. And there's also failure for a meticulous approach. All this, I think, was defined by somebody who wrote an article in the British Journal of Anesthesia, and I've shared the reference. So just thinking of the numbers, most anesthetists think that the incidence of failed spinal anesthesia is below 1%. But actually, a lot of studies have looked at this, and it's actually closer to 4%. Can be as high as 17%. This was in a study that did this, I think, did it in a teaching institution, and therefore the rates were a little bit higher, and perhaps that's too high to be acceptable. But 4% is about where people find that they can accept the failure rate. Of course, there'll be a higher failure rate in spinals that are used for any emergency surgery compared to elective surgery. So there's several mechanisms. I've just listed them down. I'll try and go into each of them in the subsequent slides. So there's failed lumbar puncture. So you don't actually even get to do the lumbar puncture successfully. Positioning of the patient can also lead to failure. Needle insertion, adjuncts, which I will also discuss, having a pseudo-successful lumbar puncture, meaning you actually did see clear liquid in your syringe and assumed this was CSF, but it wasn't, or something along that line. Solution injection errors, meaning maybe how we give our medication, dosing, and things like that. Inadequate intrathecal spread, and ineffective drug action. Failed lumbar puncture can be due to, we can group the mechanisms that contribute to this in three major categories. We can talk about the equipment we use, patient factors, and the physician factors. So I'll start with equipment. The size and length of needle is very important. So the size of needles, as you see on the right of your, I hope that is clear, on the right of the screen, there's a little table that shows just the color coding of the spinal needles we use. The spinal needles, the size, when it's very tiny, you have higher rates of failure because people don't give, a lot of people, anesthesiologists wouldn't give the spinal fluid enough time to reach the hub of the needle. And it's been shown up to 10 seconds can elapse before you see CSF in the spinal needle, especially with the really tiny needles, 27. People are even using gauge 29 now. So those might take a longer time. Of course, if you're using a wider bore like gauge 22, which is common, the black one, or the one that I would advocate for, which is the orange one, which is gauge 25, you might see it a little bit faster, maybe just a few seconds elapse. So you have to wait. And then the other thing with the needles, when studies have looked at, in terms of sizing, which ones have higher failure rates between, especially the higher gauges, that's 25, 27, and 29. And they found that though the failure rates were not different, the deformity and deviation of the needle was higher with the smaller gauge needles, that's 27 and 29, than with 25. But in terms of rates of failure, that wasn't a concern, even if you used a smaller gauge needle. Blocked needles, meaning that the hub, maybe, unfortunately, if you've been almost trying to biopsy the patient's vertebra, while you're, meaning you keep missing the intrathecal space and going into the bony prominences around it, you could get some collection of bony tissue or any other tissue that will block the hub, not really the hub, but the opening of the needle. And that might give you a false impression that you're not in the right space, and while you actually are. Now we can have a look at patient factors. On your right again, at the top, there's a patient who's having a spinal, and that patient seems to have scoliosis. If you look at the point at which the anesthetist is giving the drug, it doesn't look anywhere near the midline. And this is a factor, especially with people who have back deformities or spinal column deformities. Scoliosis also presents another challenge, which is several case reports have reported that these people do get unilateral blocks just because of how lateral sometimes you put the medication, that it doesn't spread to the other side. So the fact that the middle of the spine is, the middle of the back is not where you'll get the space, is also compounded by another complication, which is you might get a unilateral block. And there's several people who've had to do blocks on both sides just to get an equal block. So something to consider. Again, calcified ligamentum flavum, meaning that you cannot pierce the ligament with your needle. You might consider doing a paramedian approach where you will avoid the ligamentum flavum altogether by going slightly laterally from the midline and going straight into the dural puncture from there. The obese people, the body habitus does cause an impediment because you're not able to palpate the bony prominences very well. And this marker of the spinal would be having a bony prominence on top of using the intercristal line, which will be the Teffer's line. You need to at least be able to palpate some bony prominences. So, of course, obese people, and even just a person who is edematous, they don't really have to be obese, and you cannot palpate the bony prominence as well. It will present a problem when you're trying to do a dural puncture. Anxiety, meaning the patient is moving or they're not very cooperative and won't be able to give you the position. Of course, and if the patient is moving a lot, either they're confused or they're in pain, these are patient factors that would lead to difficulty in doing the dural puncture or the spinal. Again, the physician, so we have to think of positioning the patient. A lot of time in just preparing for the block, explaining to the patient, demonstrating to the patient how to position themselves will kind of prevent the positioning being poor, and having your assistant really coach the patient well will help. Incorrect needle insertion, meaning that either you're too high, you're too low. Remember that more commonly the adult spinal, so it commonly for the adults, it ends at L1, but can go up to L2. And of course, for kids, it can be L3. It can extend up to L3. So in this case, going too high might give you a bit of paresthesias. It will be more uncomfortable for the patient, and that will lead to the patient complaining and you not leaving the medication there or withdrawing your needle, and that means more attempts. Again, experience. People have looked at how many, what it would lead to, how many spinals you need to do before you can confidently say that you'll have a success rate of 90%. I think a study was done in 1996, and the learning curve is about 45 for spinals and 60 for epidurals. Now, I'm not too sure I did 45 spinals, might have been more before I was 90% successful, but yeah, apparently 45 is enough. But this is just for success rate. You have proficiency, which means being able to read your environment, being able to read the patient's, also the patient factors, and adapting to this. And of course, there's an expert level where some things you do just are in tune, and that you're very intuitive with what is happening around you. And sometimes people ask you how you did it, and you don't really have an explanation. Just say, yeah, I thought that would work. So that would be expert level. But just for, I think, competency, 45 spinals is what is basically can give you 90%. So for positioning, I'll just go a little bit deeper. There are about 3 common positions to do a spinal. So if you look on the right of the screen, you have the lying position, you have the sitting position. And then on the bottom of the right of the screen, you have what somebody who's hunched, looks like they're hunched over, and that's what they call the modified squatting position. So study was done looking at success rates between sitting position and the squatting position. And the people in the study found that the squatting position was more successful, and you required less passes or attempts at the spinal. Now that definitely was not done in pregnant women. It was done in orthopedic patients. So I'd say for pregnancy, maybe it will be very difficult with a big belly to do that. For positioning, you need a calm patient. You need to explain to them what you're planning to do. You need to infiltrate local anesthetic once you get the point that you want to start with the spinal anesthetic. And when you the reason we infiltrate, I don't think because it's a blind procedure, I don't think any of us is 100% sure that they'll get it on the first attempt, or that the needle prick is less. I mean, you're giving the patient 2 needle pricks. You need to have a calm patient to have a better success. So I'd really advocate for local anesthetic infiltration. Some people even give anxiolytics, but again, I'd think about it in terms of patient to patient. If the patient is very anxious, has no risk they're not obese, they're not going to get apneic. You can't give low doses of sedatives, and this might help calm the patient down enough, especially in the lying position. And hopefully you're monitoring them throughout. The environment, when you have a very noisy environment, unfortunately, we forget that the environmental factors, that's the time we decide we're going to drop a few instruments. There's a lot of noise, there's a lot of dragging, makes the patient anxious. If you have a calm environment and people are not maybe barking instructions or shouting instructions across the room, that will help definitely with position the patient, and they'll be more willing to listen to instruction. So for the needle insertion, needle direction is really important. Obstetric patients, because they're unable to flex, most of the time we start with doing the dural puncture in almost a perpendicular or parallel direction to the floor. But you'll notice that because the mothers are not able to flex completely, you might have to redirect your needle cephalad just so that you can get into the intrathecal space well. So redirecting the needle, that means going very slowly and really feeling and trying to map in your head what layers you're going through, what bony prominences you're feeling, whether it is superior or inferior, will help you redirect. Sometimes even lateral redirection might be necessary because you might find that you've displaced the needle and they're getting paresthesias, especially on one side. You can withdraw the needle and gently try and approach the same direction, but more in the midline. The space chosen, again, identifying the Tuffiers line, which should be the body of L4. So you get the intercrestial line, meaning you palpate the 2 iliac crests, the superior at the peak of the iliac crests, and a line drawn through that is thought to be crossing the body of T4 or the L4, L5 interspace. The accuracy of identifying this, not the Tuffiers line, but the L3, L4 spaces, which is what we usually look for, was seen to be about 30 to 40% in a study done, and several other studies I've done that actually show it could even be lower or higher, but mostly ranges about 30 to 40%, very rarely goes to 50%. So it's it's usually not very accurate, but with practice, we can get at least to approximate this. Taylor's method means that you went to a bigger space, which will be between L5 and S1, and that's where the space will be biggest, because it's the end of the lumbar vertebrae and the beginning of the sacrum. And you can do this, but just remember that because of the curvature of the back, a lot of your spinal medication will remain more distal more to the distal part of the vertebrae. So midline calcification, again, we say just attempt paramedian. So the space we like to choose is usually L3, L4. It's safe. It's away from the structures that can be injured, and it's also very close and can lead to good spread of the spinal medication. Just to touch on pseudo-successful spinals, studies were done on perineural cysts, meaning cysts that are going to mimic spinal fluid because they are between the dura and the skin. And a study done, they're looking at CT scans and MRIs, and rather radiological studies of just normal adults, say that this phenomenon is about 4 to 9%. I would gladly blame my failed spinals on perineural cysts, but I'm not sure. I've never actually seen one. They say you can do things like glucose tests for this, just to confirm, but again, not very confirmative. You'll just, if you suspect that you have a perineural cyst, hopefully you'll not do a spinal because it will be a bit difficult. Again, the other thing is when you have pseudo-successful just because of local anesthetic, a lot of people advocate for glucose, but remember that the fluid from the extracellular tissues or the interstitial from the interstitium can definitely also come and mix with the fluid that you're aspirating, and glucose test will be positive. So it's not confirmatory doing a glucose test to the fluid that comes out from the hub of the needle. An interesting one, drug addicts and failed spinal. So the studies I found is that Bayrami et al. Did a study, I think this is in Iran. I did not know Iran had very high cases of drug addicts until I looked it up. They're actually #1 in the world in terms of percentage of the population and people who are addicted to drugs. Anyway, the shorter duration for intrathecal bupivacaine was found in addicts compared to their control group, which was people who are not using. And for this, of course, they were looking at opioid drug addicts. So there's a shorter duration of intrathecal bupivacaine, so something to consider. And Mansourian, I think, is from Egypt, and they had they saw a higher incidence of failed spinal in drug addicts. So interesting that I didn't see, I haven't, maybe it's there, but I didn't come across any other studies that were big enough to mention, especially from the US, and they have a big prevalence of drug addicts. Another interesting one was scorpion bites and failed spinal. So Pandit Rao did a randomized control study of 70 patients, grouped them into two groups, some patients who had scorpion bites and the others who didn't. And he found that they had higher rates of incomplete block, and this was with spinal. And he also had done some work with just local anesthesia infiltration, like for lipoma removal, and there were very high rates of in scorpion bites patients, there were very high rates of failure of the local anesthetic drug. Another interesting thing is that I don't know where he found that many patients with scorpion bites, because if you look at his study, he says some of his people had up to 5 scorpion bites, and I thought maybe he should have eradicated the scorpions instead of continuing the study. But anyway, I think he's from Pune, so there must be many scorpions there. Raising intra-abdominal pressure, reducing the pressing on perhaps the dura and reducing the CSF, and that would mean that you have more spread with little drug. The technique, of course, site of injection, if you inject lower down the spine, you will get more spread in the sacral and the lower vertebrae, lumbar vertebrae. And if you inject higher, where before the curvature of L3, L4, then you'll have, of course, more proximal spread. Needle direction, we know this because sometimes we turn our bevel facing down if we want a saddle block when we're doing our spinals. And we can even redirect it laterally for unilateral spinal blocks. So you can either decide you're going to direct it to the left or to the right, and you can get a unilateral spinal block. If you do that, and then maybe you can tilt the patient to the side that you want to have the block, or the dependent side. So for dose selection, considerations include type of local anesthetic used. So type, when I say type, you're thinking of, you know, what type of surgery you're doing. So you're going to choose your type of local anesthetic based on this. Whether it's going to act, whether it's going to be long, short, what potency the local anesthetic has. So that will inform your dose. The baricity, more hyperbaric solutions will have a more predictable spread than isobaric or hypobaric solutions. Patient's subsequent position, whether you're going to be in Trendelenburg or you're going to be just on one side, that will determine how much dose you want. Saddle blocks, you'll need a lower dose because you don't want it to go proximal and things like that. Of course, the type of block intended and the duration of surgery. Longer surgeries, you might have to consider giving a larger dose so that it can last longer. Now, in loss of injectate, loss of even a few drops because of just how much volume we use can be significant, because if you are giving a patient perhaps 1.5 mils and your little drops cost you 0.3 mils, you have given that patient 1.2 mils, which will be lower, definitely significantly lower. If you do percentages, that's almost 30% of what you wanted to give, less than you had intended. So different manufacturers have come up with different needle tips. The first needle tip is the Lualock tip, which is the one that you screw onto the syringe, onto the needle hub. The slip tip is the one we commonly use, that we just push it. And both of this, if you think about it, can lead to displacement of the needle in the spinal space, because these are millimeters, can lead to actual displacement. So you have to be very careful and really stabilize your hand when especially with the lower lock, because you'll need to have a screw motion. And what's advocated is that your non-dominant hand, so if you're right-handed, of course, that's your left hand. If you're left-handed, you're right, is resting on the patient's back and is securing in a pinch grip, you securing the hub of the needle. Then use a screw motion with your dependent hand and try and stabilize. So you just do it clockwise, and that hopefully should be able to secure and reduce loss of injectate. Again, aspirating once you have put the needle, the syringe into the needle hub is very crucial. So Lualock is just a type of locking system. I think they're advocating now that all connectors should be seamless amongst the manufacturers. But the Lualock also has its disadvantages, because you can use a different type of drug if they all look the same. And people are starting to use like dedicated needle syringe tips for that only connect to the hub of the needle. So I think there's a move towards having, just like we have in our anesthetic gases, having pipes that are the male and female marrying are only prevent cross use. Development of new connectors is now being looked at. I think Bibron have one called the NR Fit, and they've also color coded it. And there are several other companies. The one I know is Bibron. So as I said, non-dominant hand, support the back, then put in the syringe with your dominant hand. This will prevent displacement. Again, the type of needles. So Quinky, of course, is the one that causes more headaches. Whittaker and Sprite are better because they're pencil point, they have less headaches. There are studies that have been done, and this is well documented. There's even one Kenyan study, I think it was done in Aga Khan, showed 24% headaches in Quinky, and about 4% in the pencil point. So pencil point is definitely advocated for. For the spread, just because you can see how far from the tip the hole for the medication to be given from is, even minor adjustments can lead to you giving half your drug in the epidural space, which I'll show you an example in this diagram. So if you look at on your left, I'll try and put my cursor. If you move like the spirit, if you move your needle hub just a little bit, you can lose a little bit of your local anesthetic into the epidural space, which is there, despite having a free flow of CSF in your needle. Correctly would be to have the full opening in the subarachnoid space. Again, there's also a problem with the pencil point needles, which is a phenomenon called the dural flap, where the dura actually forms a flap. So you have this free flow of CSF because it comes in here and goes through the needle and comes out through the hub. But when you're injecting, you might easily inject into the epidural space because the flap comes and closes. And instead of the local anesthetic coming out this way, it's pushed, the pressure pushes the dura back and closes the hub, and the local anesthetic escapes here. These diagrams are just gotten from Nysora, and if you visit the Nysora website, they have the diagrams and a really good explanation on this. So inadequate intrathecal spread is also another cause of spinal failure, spinal block failure. Septa in the spinal cord, which we had spoken about earlier. Spinal stenosis, meaning that the drug starts to spread, and at some point it doesn't spread further than that because there's a really tiny opening there. CSF volume. The less the CSF volume, the higher the spread of the drug. So just to remember this. Solution density, just touch a bit on the baricity of local anesthetics. At room temperature, most isobaric solutions are actually most isobaric are actually hypobaric. If you look at plain bupivacaine here, where my cursor is, this again is a ratio of the local anesthetic to CSF. And you can see that it's actually below, the ratio is below 1, meaning that it's actually hypobaric at room temperature. This makes it less predictable, and meaning that it will, with movement and things like that, you have easier displacement, either cephalad, and the incidence of patchy blocks is also higher. So it's less predictable when you use an isobaric local anesthetic, especially bupivacaine. Lidocaine is, the isobaric lidocaine is okay, but the bupivacaine is actually isobaric. Hyperbaric, which means that they have, most of the time you can either add glucose or you can add dextrose. In this case, the study was done with dextrose. The baricity is more and makes it more predictable, and hence it will spread towards the direction of gravity. So this is a diagram from Nysora. It was a really good diagram showing the patient's back. So that the point of the largest curvature is around L3, L4 there. So if you do your block here, which is L3, L4, it tends to spread more cephalad this way, and of course it will still spread this way. Especially when you're doing it with a hyperbaric solution. It's predictable, you can see that it will go this way. If you're doing it with a hyperbaric solution, below and especially L4, L5, you can see the curvature is, because it's going to go towards gravity, it is more likely to go downwards than upwards, and you might have less dermatomes being covered proximally. Ineffective drug action. So biggest complaint from anesthetists, including myself, is that my drug isn't working. So that is not the only way that you have ineffective drug action. We can talk about identification errors. Maybe you just gave saline. We have so many syringes. When we are preparing for a spinal, maybe we gave the incorrect medication. There's chemical incompatibility, the inactive local anesthetic solution is what we usually attribute to a lot of failures and local anesthesia resistance. I'll just talk a little bit about local anesthesia resistance. It's not common, and a lot of times this is usually associated with significant neurological disease. You'll find these are patients who have features of epilepsy and chronic pain. So it will not be, you'll not have a mutation without something else presenting, just because sodium channels are involved in so many other things in the body, especially neurologically. So most of the times this might be, if you have a patient with chronic pain and epilepsy, it's good to think about the possibility of having local anesthesia resistance. Again, for the identification errors, remember that all our solutions are aqueous solutions, they're all clear. And if you're not using syringes that are color-coded, there's a danger that we could land into trouble and give the wrong medication. Several studies have been done, including some showing that a patient was given tranexamic acid or whatever it was, many other medications through the spine. So it does happen. So chemical incompatibility, I'll just touch a little bit more on that. When you use more than one adjuvant, it may lead to ineffectiveness, especially because some of these adjuvants, if you use more than one, they might lead to precipitation of the solution forming salts, and that would lead to maybe the lower doses of the drug being given. For the opioids, most of them are shown to be effective when mixed with the local anesthetic, but when you mix two opioids, studies haven't really looked at that, and it might not be as effective. So be very careful doing that. Again, when you mix more than one adjuvant, you may lower the pH. And once you lower the pH, remember a lot of our local anesthetics depend on our pKa, and the pKa is basic for a lot of them. There'll be some are 8, some are 7.8, some are up to 10. So if you lower the pKa by lowering the pH, you have less drug in an ionized form, and the unionized form is the active form of the drug. And if you reduce the amount of active, what is going to act on the site of that is desired, then you'll have reduced action of your local anesthetic. So just remember that the more things we mix into our medication, the higher the chances that we will lead to some of these things. So when we look at drug failure, I just saw something from AstraZeneca, that the people who looked at in a 6-year period leading to December 2007. So it was, I think, 2001 to 2007. They looked at all the complaints they got, and they got about 562 complaints. A third of these complaints were actually from the UK. Although they say that these complaints are from everywhere where they had marketed their product. The conclusion was that of all the samples they analyzed, none of them were seen to be out of what they specified as the manufacturer of this product. So they thought all samples were okay, and perhaps there may have been an error in the anesthetics. One thing I know is before we make a complaint, it has to be, we can make a complaint about a batch and maybe 1 or 2 anesthetists have seen the same thing, or you have more than one patient having failed spinal. So I found that very interesting. There's also, I think Baxter published something and about their returns, and they also did not seem to find anything wrong with their samples. So as much as we blame drugs a lot, it might have been any of these other factors we have mentioned. So I'll go into prevention. The mechanism is really important, because if you know what happens when things go wrong, you might be able to prevent it. So failure of subsequent management, which we think is not taking care of the factors that are around the patient while we give the spinal. So the patient, reassuring the patient, talking to the patient really helps in terms of other sensations the patient will feel. Although things like cold and pinprick may have gone, the other sensations, the patients might perceive them as pain, and it's up to us to assure them that the light touch they're feeling is normal, and that the block is actually working. So light touch is one of the last sensations to be blocked, and it's one of the first ones to come back. It comes back even before pain and things. So it's very important to just allay the anxiety. Again, just remember the environment. The bed is really hard. The patient has been supine in one position for a long time. There's a lot of noise. So allaying anxiety will also help with preventing the patient from becoming anxious and telling you that this block is not working, I want to go to sleep. Ultrasound is another new thing that has come, and more people are using it to try and reduce the difficulty in doing and identifying the spinal space, especially in places where the bony prominences are not easily palpable. On your right, you can see in the first figure, the person is holding this in a coronal, I'd say transverse, and that's how it looks. This is like a whole day lecture. I'll not really go into it, but basically you're looking for the ligamentum flavum and the intrathecal space. So ligamentum flavum is there, intrathecal space is there. So you have your transverse processes, your lamina, and you're going to, this person is doing this pre-spinal, and they're going to mark the area. There's also people who are trying to do this real time. The difficulty in doing this real time is that this is a really bulky probe, and you cannot do it, the space for you to do the spinal and the probe is not enough. So you might have to do it, my apologies, that was, so you might have to do it a little bit more towards a bit more laterally, but in the sagittal plane. So you're going to do it parasagittal, and it's a very difficult thing because it's easier to do it as a 2-operator procedure. It's a curvilinear probe most of the time. So you'll mark it once you do the transverse and then the sagittal and where they intersect. So you look at where the line is and then count your spaces. So the line would be the sacrum, and then the first space will be L5, S1, and then count subsequent numbers up to L3, L4, and then you can mark it. Again, testing the block also prevents you from block failure. So the questions I like to ask myself is, how do I know the block is working? So I'll have to test it. How long should I wait before I say this block is definitely not working? Usually 15 to 20 minutes. Do you really have 20 minutes in theater? Unlikely. There'll be a lot of anxiety around you. So maybe from around 10 to 15 minutes, you might have to start managing your block if it's not working well. Then look at what you can do better. Position the patient, make them comfortable, and use the adjuvants that we've mentioned. So testing for the block, this has become very controversial. Most people use cold sensation commonly. Just remember that the onset, apologies for the typo, the onset of bupivacaine is about 5 to 8 minutes. So asking the patient to move their legs before 5 minutes, definitely the patient will move and they'll become anxious that it's not working. So give it time, maybe distract the patient, do other housekeeping things. And as for the testing, you're going to test both components, sensory and motor. Motor is the easiest, Bromage, which categorizes from 0 to 3, 0 being patient with categorizing your movement from 0 to 3, from no movement to movement, complete movement. So 3 will be patient who cannot move their legs. Now, cold sensation is mostly used when they look at what people do. Ethyl chloride is very common because it's standard. Is it the best? People have said touch would be better, light touch, because a lot of times you test cold, but the patient still feels touch. So light touch to T6 is the one that they advocate for, but the schools of thought are so many and everybody's argument sounds plausible. So whatever you use, just make it consistent and tailor it to the kind of surgery that you're doing. So when we're managing the failed spinal, we'll think of three things. Either we can rescue the block, can repeat the block, or we can convert to general anesthesia. So rescuing the block before incision, we can categorize, we'll do it, either we rescue it before the incision, or unfortunately they manage to start the case and your block now is patchy or is inadequate and you need to rescue it. So if it's before the incision, you can put the patient head low, try and get more cephalad spread to cover more dermatomes. Hip flexion, it will limit the spine curvature. So just flex the hips. It might not be very possible in the obstetric patient, but for your other patients, you can do hip flexion. Valsalva maneuver and coffin I found very interesting. They're listed as such. I tried to look up how it's done. I didn't see any studies that are actually doing Valsalva intra-op, but it's about epidural volume expansion. Valsalva maneuver would increase your intra-abdominal pressure, hence reducing your CSF and making the displacement of your drug more cephalad. Does that really work? I'm not sure, and you'll have to quantify it. Coffin, I'm not sure is a very good idea, especially in the times we're in, but I have never done any of this. Maybe I'll get comments from the audience as to if anybody has done any of this. So if it's after the skin incision, we'll think of communicating and of course reassuring. Systemic analgesia, so you can either decide to sedate the patient or you can decide to just give analgesics. And sometimes we do both. So you can give a benzodiazepine or any other sedative, or you can decide to go systemic analgesic with strong opioid or any other analgesics that you are at your disposal. Remember that your aim is just to give analgesia or sedation. It's not, you've not opted for general anesthesia yet, so titrate your doses. Local anesthesia infiltration is also a possibility, and you can use it, especially if you're confident enough that the other facets of your spinal are working, and it's just one area. General anesthesia is usually the last recourse, and once you reach there, it's still okay to do it because the patient should not have surgery in pain. So just a reminder, intrathecal adjuvants do not prevent block failure, but they improve quality and prolong the block duration, but they will not prevent you from getting a failure in terms of your spinal block. A little bit about repeating the spinal. So if after 20 minutes, then you can repeat the spinal. Sometimes you don't have this much time. So if in 15 minutes you're sure that the progression is not as you'd like it, you can opt to repeat. Again, case by case analysis, look at preferably elective procedures, or maybe it's emergency and the risks of general anesthesia are not, you're not willing to take them. That would be a good idea to do a repeat spinal. Reducing the dose by 25 to 30% of your subsequent repeat is good, because sometimes, as we have seen in the previous diagrams, some local anesthetic has entered the spine and you might easily get side effects like high spinal hypertension. So try and reduce your dose, and this is advocated for. Most of the times, we shouldn't repeat the intrathecal opioid, again, because of the effects of having high doses, especially the long-acting ones like morphine. You might lead to respiratory depression later. The next thing we'll look at is conversion to general anesthesia. This is, of course, not very ideal, more complications. Remember to communicate with your patient. It shouldn't be a surprise. Tell them that you recommend that they sleep because the surgery needs to continue and they're not able to bear it with the current situation, and mitigate for the risks of difficult intubation, the aspiration. And remember, your block might work later and there's a possibility of getting hypotension later. Specifically for unilateral blocks, try change your position, tilt the patient to the unblocked side. That might help. And for patchy blocks, infiltration locally using the systemic analgesics or repeating the spinals will rescue your block. So I think I'm almost at the end. Hopefully I'm not, some of you are still with us. My take home from this talk is we should create a conducive environment for spinal anesthesia. Slow, careful injection of the medication so that we don't have loss of the injectate is very good, so that you have your dose and you can diagnose failure very early. The other thing I would advocate for is once you finish your spinal, do not withdraw. Once you've given all the drug, do not withdraw both the syringe and the needle. Disconnecting the syringe from the hub also lets you make sure that there's no displacement during the connection. And so you'll disconnect the syringe first or wait for to see CSF flow, backflow to the hub. And once you see that, then you can confidently say, I have sometimes had to repeat my spinal at that point and just get a little bit of a dose because I think I displaced my needle, and that has helped reduce the rate of failure. Rescuing the block early is good because you give confidence to the patient, to the surgeons and the rest of the team. And definitely sometimes you'll fail. There are factors, it's a blind procedure, there are factors that are beyond our control or we cannot see, and accepting that is fine. So my talk ends there, and now to why I like the movie 300, I think Angie. 300 is about a battle fought by Spartans and Persians, and against all odds they triumphed. So apparently 300 Spartans were able to hold a whole army. I highly doubt the only 300 sounded more when you look it up. The reason I like it is because I didn't understand why they decided not to wear any shirts, and definitely I have body goals. So that's why. That ends my talk. Thank you very much. I'd be happy to take any questions.
Thank you very much, Dr. Kamau.
Hi. Sorry. Thank you, Dr. Kamau. Sorry. Thank you so much for your presentation. That was quite a thorough walk through the dreaded murky waters of failed spinal anesthesia. I must confess, Kamau, I was hoping there'd be a bit more, it's not you, it's the medicine, something along those lines. But I suppose my ego will have to take it. So I do believe we feel a lot better armed to troubleshoot in these sorts of scenarios. I'll let you have a breather and go through the chat slowly.
Okay.
And we'll take the Q&A session at the end. We'll just take another maybe 10, 15 minutes to welcome our partners for today's webinar. We welcome Troikaa Pharmaceuticals. They specialize in anesthesia and pain management drugs, and they are ably represented this evening by their country manager, Mr. Aditya Rai. Aditya, we are happy to give you the stage to tell us more about your products. Welcome. Welcome, Aditya.
Thank you, Dr. Angela, and thank you, Dr. Kamau, for this presentation. I know it's a very sensitive topic, but thanks for choosing and thanks for presenting this topic. So once again, I welcome everyone on behalf of Troikaa Pharmaceuticals. Many of you may know about Troikaa or maybe some brand called DYNAPAR. So I'll straightforward go and so this is the product I'm talking about, DYNAPAR injection. Many of you must have heard or use also and must be having some good feedback. And then this is the product related to today's topic, Bupitroi heavy and Bupitroi plain. We have both preparations available, plain injection and heavy also. And then just a brief introduction about the product which we are dealing in case of anesthesia. We have our fentanyl called Trofentyl. We have our propofol called Propofol. Then we have our ketamine, that is Ketamax. We have our midazolam, benzocaine, that comes in 3 ml and 5 ml both. And then we have our gases, that is isoflurane, Isotroi, and sevoflurane, Sevotroi. So I'll take you through a very small and brief presentation about pain management. So there are, I mean, as most of you know that there are conventional 3 ml injections available, and then DYNAPAR AQ is available. So what is the, limitations of 3 ml injection? That is, I'm going to brief. So the 3 ml injections, the route of administrations are two. One is intramuscular and the second one is intravenous. So when it comes to intramuscular, it is only gluteal route of administration is available. And you know that limitations is pain at the site of injection, and then compromised bioavailability in case of patient is obese. Right, and the pain at the site of injection is the most common thing, which as a doctor you must have observed in many of in a patient, because of large volume and propylene glycol presence in the injection. It gives a lot of pain to the patient. And imagine a patient walking to you and asking for pain management and end up giving more pain because of injection only. So the 3 ml injection, because of high osmolality, propylene glycol is already known to cause more than 10 times injection pain and more than 50 times phlebitis as compared to other formulations available in diclofenac. And this is the small study was done, and it was found that only 32% of patient, in only 32% of patient, drug reaches to gluteal muscle, and 68% patient, it was found that drug was deposited in subcutaneous fat because of high fat layers at gluteal region. And this is the same thing. So yeah, the limitation, the main limitation of IV route is it can be given only IV infusion, and then it offers the slow onset of analgesic effect. And the third one, very important, it needs buffering agent like sodium bicarbonate to adjust pH, and then high risk of thrombophlebitis. So these are the limitations of 3 ml injection, conventional 3 ml injection in case of diclofenac injection. So we thought that let's offer something much better and much more convenient for the doctors and for the patients also. And here we came with DYNAPAR AQ, 75 mg in just 1 ml. And this drug, this injection is manufactured by US patented Aquatech process. And how it is superior, how it is better, how it is convenient for you and your patient, I'll just brief in a few slides. So as compared to other diclofenac available, the conventional 3 ml available, DYNAPAR AQ is propylene glycol free, which results in significantly less phlebitis, right? And then it gives you a more route of administration, additional route of administration for the drug. First one is the deltoid route. DYNAPAR AQ is the only injection which can be given intradeltoid, right? And which offers the consistent efficacy and convenience. And then this is the only injection which is approved for IV bolus route of administration along with IV infusion. So IV bolus gives you the faster onset of action, faster onset of analgesia. So DYNAPAR AQ certainly has a benefit of deltoid route of administration and IV bolus route of administration. So here the head-on comparison between 75 mg in 1 ml, that is DYNAPAR AQ, and the conventional diclofenac 75 mg per 3 ml injection, that is the conventional one. I'll not take any particular brand name, but you all know that there are a whole lot of 3 ml injections available in the market. So, I mean, as I earlier said, that DYNAPAR AQ is virtually painless at the site of injection. It has a versatile route of administration. First one is intradeltoid, which is most commonly used, and then intragluteal, then IV infusion and IV bolus. And then it gives advantage over, I mean, the advantage of deltoid route of administration is that it is very convenient in case of OPD, although it is not very significant for the anesthesiologist, but yes, it is there. And then the second one, no embarrassment to the female patient. Again, it is not very related to anesthesiologist because you are there in the OT. And then advantage of IV bolus, it gives the very faster onset of analgesia, lesser incidence of thrombophlebitis, and no need of infusion line. Hence, it is very cost effective for the patient also. So this is all about DYNAPAR AQ. And I'm proud to say that most of the hospitals in Kenya, in Nairobi, DYNAPAR AQ, our brand DYNAPAR AQ is available. I'll just name few of the important ones like Nairobi Hospital, Aga Khan, Mpisha, Avenue, Mater, AIC Kizabe, Karen Hospital, Medihill, Gertrude Children's Hospital, Nairobi West, and various mission hospitals. They are using our DYNAPAR AQ very comfortably since long time with the efficacy and with satisfaction. So I hope I'll get more support on DYNAPAR AQ. And then I'm moving to a small next presentation, that is Bupitroi Heavy. It is our bupivacaine 5 mg per ml. That's a 4 ml ampule. It's a pack of 5 ampules. And yeah, it is, there's no preservative in this. Then the question comes, why you should, anyone should use Bupitroi heavy. So here are the answers. It is manufactured by fully automated, hands-free line with dual sterilization. And the second important factor is the terminal sterilization of finished product is followed by ETO sterilization of blister pack. What is that? I'm just going to give more details on this. The sterilization, number one, that is finished product. The ampule is subject to autoclave sterilization. And the second one, which is more important, that is the blister pack is subjected to ETO sterilization. So here, the advantage is you just need to take out the ampule from the pack and you can directly use. So the third point, why anyone should use Bupitroi heavy, it has 1 point cut OPC. So which is very easy to handle the, use the drug, and it prevents microparticles of glass. It doesn't fall in the ampule, so less chances of any contamination because of ampule or glass. So these are three important factors why anyone should use Bupitroi heavy. So Bupitroi heavy, presenting you Bupitroi heavy crafted with utmost care and cost effectivity. With this, okay, these are my contact details and my team. So if anyone wants, they can contact Shelmith. She is having my contact number. If anyone wants anything about the product or something, they can contact us. Harley is our distributor here in country. So thank you very much. I have not taken much time, I hope. And stay safe, everyone. Have a very nice evening and nice discussion again with Dr. Kamau. With this, I rest my presentation. Thank you.
Thank you, Mr. Aditya. Thank you so much for your presentation. Your products are a staple in many of our clinical spaces, and we look forward to working with you. And thank you for supporting this exchange of knowledge. We appreciate you. So now for our delegates at large, we'll enter the Q&A session now. Dr. Kamau, you're at hand.
Yes, so I'm just looking at the chats. Unfortunately, Angela, there'll be no time to discuss my movie choices. It looks like there are too many questions. So
I feel like saying thank God for that, but no, I was really looking forward to that.
That was a story, as I said, but maybe I'll start with some of the questions. I'll try and answer as many that I can. Some I might ask for a few comments from the audience.
Okay.
So there's a question.
We'll have a sorry, Kamau. So we'll take this session to maybe 7:25. So and maybe 12 minutes before we close. Yeah, that's okay. All right. No, you're a champ. Thank you.
All right. So I'll start with there's a question about the squatting position that the study that was done in orthopedic patients. So as you let me try and share the screen again. So this position, how were orthopedic patients able to sit? It was done in elective orthopedic patients. So perhaps people who are doing knee arthroscopy or any other orthopedic case that was not an emergency or the patient was not in pain. That's why they were able. There was a question asking how come it was able to happen. So that's why. There's a question about the Pavlov cyst and saying it could be CSF. That's quite true. The cyst is seen in the epidural space. So what happens is that there's an entire cyst with fluid in it. And when you puncture, it fills, the wall of the cyst would mimic a dural puncture. And somebody was just asking that I explain better the mechanism of that. There's a question on having a patient with repeated attempts. The patient is coming for cesarean section and also has had chronic back pain as a result of road traffic accident. What complications to expect? I'd say this is one of those tricky ones because one, you really want to make sure that the surgery is safe for the baby and the mother. So yes, spinal anesthesia is not completely contraindicated unless you have existing back pathology that would prevent you from doing it. So the many attempts might be because we don't know. I'm not sure if you knew why she had chronic back pain. Did she have osteophytes there? Was there any deformity in the back? The things I'd expect due to the many attempts would be headaches, post-dural puncture headaches, and maybe if it's very bad, they can get epidural hematomas. Just remember that the pathophysiology of a post-dural puncture headache, when you have CSF leak due to multiple punctures, that CSF leak leads to pulling of the brain, because the CSF in the spine and in the brain is the same system. And when you pull when there's a pull, the veins that connect that come from the brain all the way to the skull, some of those veins they are not tortuous, meaning that they rupture easily on tension. So when you lose CSF, there's tension created as the buoyancy of the brain is reduced, and that rupture of the vessels can happen because the brain is under tension, it's pulled, and then you have rupture of the vessels, so you can have an epidural hematoma. So I'd be careful about number of punctures and trying to limit those. There's a question on back pain. The back pain question was, what my opinion on back pain and spinal anesthesia, especially in cesarean section. So back pain is basically multifactorial. When they look at people who've had general anesthesia and spinal anesthesia, especially cesarean section mothers, back pain is multifactorial. Progesterone is known to relax ligaments. That makes the back a bit more flexible, and that can lead to pain. Also, the spinal anesthesia has not been directly pinpointed. When you look at the rates of back pain between general and spinal anesthesia, they're not very different. So it's multifactorial. I would say, especially if they have back pain before you do the spinal, I wouldn't attribute the back pain just purely to the spinal anesthesia. Hopefully it does resolve once the progesterone levels get better and the patient gets stronger. There's a question about using an introducer, especially the tinier needles. I advocate for it quite a bit. Remember that the smaller the gauge of the needle, the more the deviation, and there have been incidences of even spinal needles breaking in the back, and anesthetists are not equipped to go and get it. We'll have to do a small laminectomy or something to go and retrieve it. So using the introducer guarantees that, especially where the tissues are very tough, which will be the skin, a bit of the subcutaneous tissue, the muscle, okay, not really muscle, but the tissues that just before you get to the epidural space, if you can bypass most of that, it can try and limit the bending or the deviation of the needle. So I advocate for using the introducer, of course, after local anesthetic, because the introducer will be a large gauge, might be even up to 18 or 20 gauge. There's a question on barbotage and whether we should use barbotage. So barbotage is no longer advocated for, just because it leads to, when the studies have looked at barbotage, it leads to a more patchy block, where you have more areas not being covered by the neuraxial block. So for barbotage, the studies that did it, what they describe is that you actually give, maybe if you have a 3 ml medication you're giving, you give 1 ml, then you aspirated another 1 ml, then you give 2 mLs of that total solution, and I mean that continuous bringing back CSF is not advocated for. However, gentle aspiration to confirm whether your position of your spinal is correct has not been shown to have any differences. Again, people looked at even things like the speed of injection. They compared whether you gave it very fast. Very fast was like something like 0.3 mils per second. I'm sure some people can give faster than that, but they looked at the height and what effects they had. They saw that people who gave slowly, the onset was faster, but also the duration of block was shorter, actually, not long. And the people who gave fast, the height of the block was a bit more, and the duration lasted longer. But I wouldn't give it too fast. Remember, you might lose injectate in that procedure, and also you might displace your needles. Now, there's a question on additives. Which one is best? Sorry, there's so many questions. I'll try and go as quickly so that I see if I'll be able to finish them. Which one is best? I think this question was on opioids. Now, it depends on what is in your market. There are people who will have alfentanyl, sufentanil, fentanyl. There are people who will only have morphine, people who only have pethidine. I'd say that you'd have to look at which one you have with you and look for the ones short-acting opioids work very well because they don't give you prolonged respiratory depression afterwards. And also you're thinking about what surgery you're doing. Remember, if you use a long-acting one, just to think about things like urine retention, like morphine or even pethidine, you might have urine retention later. You might have delayed respiratory depression. So I wouldn't say which is best. I would use it case by case. What surgery you're doing, what are your goals, and the condition of the clinical condition of the patient. Pain on delivery. There's a question about why do the patients sometimes complain of pain after the baby is delivered? I would say just remember that the peritoneum is supplied by up to T6, and when you're delivering, you're going to have a bit of peritoneal stretch. So if your block height is not up to T6 or is inadequate, the body will, you'll think you have adequate block, at least for the incision and reaching the baby, but on delivery, that stretch will give you some pain. So I would think it's more of the stretch. Also, the sensations, as we said before, could be a factor, and just to reassure. And if the patient is very uncomfortable, you can consider systemic analgesics. Shoulder pain with I think this must have been a cesarean section. It's again referred pain, T4 from visceral pain. Sorry, this will be visceral pain from peritoneal stretch. So it's usually referred, especially to the left shoulder. I was told to comment on pethidine and using pethidine for saddle blocks. So I know sometimes where pethidine is seen to be a good drug, I'd advocate for using hopefully a preservative-free medication. Pethidine has local anesthesia-like effects, and so a lot of people use it for saddle blocks for quick procedures. Just to remember that pethidine also causes a very high incidence of urine retention. So if you're doing these cases for day case, just to remember that. Sometimes I would advocate more for using a low-dose local anesthetic than using pethidine, especially if it's preservative-free and if it's a day case. But it has been used as a sole anesthetic. But yeah, just keep that in mind. So somebody asked, how many times can I repeat a spinal? I'd say just once. Try not to repeat because I'm not sure what would make me repeat more than once. And then there's something about comment on doses of spinal anesthesia in general. This one is difficult because, again, it depends on the type of patient, the height of the patient, what local anesthetic you're using. So I'll just say beforehand, when you're doing your pre-anesthetic review, have all those, of course, talk to the surgeons, find out what surgery they're doing, and that will inform you the approximate duration. And then now you can adequately dose your spinal from there. The last one I'll tackle is current management of posterior puncture headache. So currently, before we thought that giving the patient complete bed rest for post-dural puncture headaches, that giving the patient complete bed rest, hydrating them, giving them coffee, giving them things like aminophylline or theophylline, that was seen as to be conservative. I think there's also dexamethasone, there's pregabalin also has been looked at. Complete bed rest, especially if it's a post-dural puncture headache, has not been shown to be effective. If the patients are able to ambulate them. Caffeine, again, the studies did not show any clinical significance for patients who got caffeine and those who didn't. And hydration is good because you eliminate the fact that dehydration is a cause, and you continue. It's thought that if the patient is well hydrated, perhaps production of CSF will be okay and the leak will not be so significant. The other thing is that in PDPH now, definitively epidural blood patch, it's thought to be effective around up to 70% with one blood patch, and up to 95% if you repeat the blood patch. So when you're telling the patient you're going to do an epidural blood patch, just remember to say that this is up to 70% effective. It might not, you might not be 100% after that, but we can always repeat it and we'll get a better outcome. Also, most of prophylactic blood patches are not advocated. That means you did many punctures and then you think, no, those are too many punctures, I will do an epidural blood patch, just because the incidences, the prevalence of the headache is not enough for you to say that everybody will get a headache. Some people might escape it. And of course, the patch is not without complication. Angie, how am I doing for time?
Chasing you down.
Okay, I'm done.
Yeah.
I don't think I'll take any more. I'm so sorry. There are really many questions. A lot of them are not even to do. It looks like I probably a Q&A with regional anesthesia people would be nice, and they can really help with this.
But this was excellent, Kamau. This is excellent. It's really generating nice, rich discussion. You can see, I think we'd be more worried if there was no question coming in. So this just shows how pertinent, how relevant this is. Sorry, let me just chase down some mics.
Okay, there's just one that is really interesting. What is the relationship between failed spinal and drinking camel milk? Wow. I'd say that's material for study. Yeah, I have no. That's the most new one. I think that's Mohammed. Yeah. Okay.
I can't help you there.
Yeah.
You're on your own.
Okay.
Oh, thank you. But honestly, Dr. Kamau, thank you so much for your presentation. You are just getting such raving feedback and reviews. And we are so glad that our delegates feel that it was an edifying experience. Thank you for the time, the research, excellent presentation. Thank you for everything. Our sponsors, Troikaa, for working with us, not just today, but in our regular clinical spaces. You, our esteemed delegates, thank you for joining us. As always, we long for these days and we enjoyed them. KSA Executive Committee, we thank you for organizing and running this CME calendar. Our KSA family, our members, Ms. Shelmith, Macharia, for all your efforts and all your organization. Thank you so much. Remember to subscribe to our YouTube channel. Just search KSA and visit our website where we do upload our presentations. For those of you asking for the slides or presentations, it's all uploaded and it will be there maybe in the next 24 hours. We welcome you to share your preferences and suggestions as regards the matter we tackle, because your comments, your criticisms, your contributions are exactly what make this a rewarding interaction. And with that, we ask that you accept our standing invitation for our weekly webinar. Next Thursday, same time, same place. Good night, family.